The challenge in assessing children with special health care needs is determining what is normal for that specific child. Your best sources of information are the parents of the child, their health care providers, or their guardians who provide their care. They will be your source of normal so that when assessing them, you can determine if the findings that you have are normal or abnormal for this child. Always take a conservative approach. If you are not sure, assume that any abnormalities are abnormal until proven otherwise. In addition to this difference in the way you approach assessment in a child with special health care needs, you will also have to concern yourself with subpopulation called technologically assisted children. These are children who rely upon medical devices to maintain life-sustaining functions, such as airway, breathing, circulation, or nutrition.
As with all patients, airway is the first step in the care of the child with special health care needs. The one major difference may be the presence of the tracheostomy tube. A tracheostomy tube is a device placed through the stoma, which is a surgical opening of the airway, usually found in the front of the neck, that bypasses the upper airway and provides direct access to the lungs. This is often placed when the child has a problem with the upper airway and needs to be on a home ventilator or needs access to the lower airway for suctioning or maintenance. The care of the patient with the tracheostomy tube includes assessment of the tracheostomy. There are two steps to this. One is to look at the site, and second is to attempt to ventilate through the tracheostomy. If you encounter resistance or an obstruction while attempting to ventilate through the tracheostomy, remove the BVM and go on to steps to help clear the obstruction. In order to suction the patient with a tracheostomy tube, first assure that they are adequately oxygenated, then remove the bag. It is often helpful to inject a little saline to loosen up secretions. Then, using a soft suction catheter, insert it through the tracheostomy, just slightly in, and withdraw with suction applied. Prior to repeating this technique, assure adequate ventilation. If you are unable to clear an obstructed tracheostomy tube with suctioning, you may have to remove the tracheostomy tube. In order to remove the tracheostomy tube, cut the ties, remove them, and then pull the tracheostomy tube out in line with the patient. Once the old tracheostomy tube has been removed, you have to insert a new tracheostomy tube. To do this, there are two methods, the direct and the facilitated. In the direct method, you take a tracheostomy tube, insert the obturator to make it stiff, then insert it through the stoma in the anatomical manner. You then remove the obturator from the lumen of the tracheostomy tube and attach a BVM. Attempt to ventilate to confirm correct placement. If you have good bilateral chest rise without resistance, the tracheostomy tube is properly placed. If you do not have this, try again. Another method for inserting a tracheostomy tube is the facilitated method. In this method, you use a suction tube as a stylet. Take the tracheostomy tube. Insert a soft suction catheter through the tracheostomy tube so the suction catheter extends past the tracheostomy tube. Then, place the suction catheter in the airway and slowly advance the tracheostomy tube over it. Once the tracheostomy tube is properly placed, remove the suction catheter and attach a BVM to confirm correct placement. Again, good bilateral chest rise and no resistance confirms correct placement of the tracheostomy tube. If you are unable to replace the tracheostomy tube, your first step should be to try a tube of a smaller size. If this is unsuccessful or another tracheostomy tube is not available, you will have to use an endotracheal tube instead. Choose an endotracheal tube of the same internal diameter as the one of the tracheostomy tube. Then, insert the endotracheal tube into the stoma, only to the depth that is equivalent to the length of the tracheostomy tube you've removed. Once inserted, attach a BVM, again, to confirm correct placement. With assisted ventilations, bilateral chest rise with good breath sounds and no resistance confirms correct placement. If correctly placed, secure and transport the patient. Some children with special health care needs will be found at home on a ventilator. The ventilator may be used if they have a weakened respiratory drive or weak respiratory muscles that cannot adequately ventilate on their own. In either of these cases, ventilator use may be continuous, at night only, or in periods when they are sick. For pre-hospital care providers, there are two key considerations: the assessment and management of the patient. Assessment is necessary when the patient has respiratory distress. The simplest technique is to take them off the ventilator and attempt to ventilate them with a bag valve mask. If you feel an obstruction, you know there is an obstruction in the airway, most commonly the tracheostomy. If they get better when you take them off the ventilator and you assist ventilation with a bag valve mask, most likely the problem is in the home ventilator itself. Lastly, if they maintain respiratory distress when you take them off the ventilator, the problem is most likely with their lungs or another cause of respiratory distress that has nothing to do with the airway or the ventilator. In management and transport of these patients, you must always remember that any patient on a ventilator can be taken off and assisted with a bag valve mask. In most cases, this will be easier than attempting to figure out how to set the ventilator, how to adjust it, and how to take it with you on transport. The key things to know about a ventilator are there's an oxygen setting and a breath rate setting. When ventilating a patient, you should ventilate them at least at this rate and oxygen setting. Any patient in distress should have their oxygen turned to 100% and should be ventilated on 100% oxygen. In addition to the ventilator itself, there is a circuit which allows the ventilator to be connected to a patient. At the end of the circuit is a final connection piece, or elbow. This is what attaches a patient's tracheostomy to the ventilator. When attempting to ventilate the patient, disconnect at the elbow and connect the BVM at that location. Many children with special health care needs will have surgically implanted central catheters. These are often placed because they require frequent vascular access, or vascular access is difficult to obtain. Some children with special health care needs may have feeding tubes. Feeding tubes are devices that allow the delivery of medication or the delivery of supplemental nutrition in certain children. These devices can help you, the pre-hospital care provider. If the patient has gastric distension, you can open any of these devices to outside air to allow the air to drain and thus treat the problem. In addition, as a pre-hospital care provider, you must remember that these devices are attached for supplemental nutrition or medication delivery. In order to transport these patients, it may be easier to disconnect them from the device. There are two broad categories of feeding tubes: those that are temporarily placed and are placed either through the nose or the mouth and are called either nasogastric or orogastric tubes, and those which are surgically placed, in which a catheter is inserted through the abdominal wall. Surgically placed gastrostomy tubes or temporarily placed nasogastric and orogastric tubes are often used at home by children with special health care needs to provide enteral feeding. The most common way this is done is with the use of a feeding pump connected to tubing, which then is connected to an end piece, which attaches a patient to the device.